My name is Boryszewski, and I'm the Paramedic Program Director at Loyola. I'll be walking you guys through the Emergency Cricothyroidotomy skill, also known as FONA, or front of neck access, for emergent can't intubate, can't ventilate scenarios. In order to get started, you're going to need a couple things. It's always important to pre-plan your procedures so you're not fumbling around looking for any piece of equipment. First and foremost, you need to make sure that you're wearing a mask if you're not wearing one already. You need to obtain a 10 or 11 blade scalpel. Doesn't matter which one, both will work for this procedure. You need to make sure that you obtain a 10cc syringe as well as a new 6.0 ET tube. You also need some method of securing your tube, so a commercial tube securement device will work in this situation, or you can utilize tape as well. You also need to make sure that you're wearing eye protection in the event of any sort of blood splash or splatter. Optionally, certain providers may have the tactical Cric kit, as we refer to it as. This also contains all of the items needed to perform an emergency cricothyroidotomy. First and foremost, you need to identify your landmarks. So the location that we're going to make our incision and place the tube is going to be right here, or the cricothyroid membrane. When it comes to identifying that landmark, the easiest way to do that is to first, I prefer measuring twice, cutting once. So I'll stabilize the patient with my dominant hand, and I'll place my index finger on their chin, working my way down. The first hard portion that I'm going to feel is going to be the hyoid bone. Then working my way down, I'm going to feel another hard cartilage. That's going to be your thyroid cartilage. I'm going to feel a soft spot where we're going to make our incision. And then I'm going to go ahead and go down and feel that first cricoid ring. So between the thyroid cartilage and that cricoid ring is our cricothyroid membrane, where we're going to be making our incision. After you've identified your landmarks and you're ready to begin the procedure, make sure that you have your appropriate PPE on, including a simple mask, eye protection, and gloves as well. So I'm going to go ahead and preload my syringe on my ET tube, so that's one less thing for me to worry about when it comes time to actually inflate the cuff. And I'm going to go ahead and select my scalpel. In this case, I'm going to be using a number 10 scalpel. As you mentioned, 10 or 11 blade will work. And then you also want to make sure that anytime the scalpel is not actively being used to cut your patient, that it is in the safe position. These safety scalpels, if they're used properly, do prevent a whole lot of erroneous or accidental lacerations to yourself or your patients potentially. So I'm going to go ahead and hold my scalpel like a pencil, and I'm going to go ahead and stabilize my patient with my non-dominant hand, as I'm going to be doing all of my incisions with my dominant hand. I'm going to go ahead and open my scalpel blade, and I'm going to go ahead and make about a 1.5 to 2 centimeter vertical incision midline of the trachea. And I'm going to start just about 0.5 centimeter above where I've identified my cricothyroid membrane. You might need to make multiple passes in order to appropriately expose the cricothyroid membrane. That's okay. Make sure that you make multiple passes in one direction. I think of it as painting instead of sawing back and forth. So if you make multiple incisions, the skin should start peeling back a little bit, and you should be able to identify the cricothyroid membrane fairly easily. If not, you may be able to utilize a pair of curved Kelly forceps in order to perform a little bit of blunt dissection and spread some of that tissue. Or alternatively, you can apply some downward pressure on the skin as you're going through the subcutaneous tissue and the skin layers to open that up a little bit. So once you've visualized the cricothyroid membrane, go ahead and turn that scalpel 90 degrees, doesn't matter if it's clockwise or counterclockwise, and go ahead and make a 90-degree plunge cut about 0.5 centimeter deep. You will not need to apply a whole lot of pressure. The scalpels are sharp and they'll penetrate the cricothyroid membrane fairly easily. After you make your initial plunge cut, go ahead and extend your incision laterally about 0.5 centimeter. rotate that scalpel 180 degrees as it's still inside the patient, and then extend laterally in the other direction. Now you should have something that looks like a plus or a cross right over the cricothyroid membrane. I think of that as a good landing zone for your ET tube. Go ahead and make that scalpel blade safe, and you can also take the handle end and then utilize that to dilate the tract where your ET tube is going to go a little bit. Then if you keep that handle of the scalpel inside your opening, it'll help you identify landmarks a little bit. In patients that do have a little bit more subcutaneous tissue, you can utilize, if you do have it available, a tracheal hook to kind of lift some of the tissues out of the way and place the trachea in a more immediate view. Then go ahead and take your 6.0 ET tube and then insert that into the incision that you've created, inserting until the cuff is just past your incision. Afterwards, go ahead and inflate as you normally would to an appropriate pressure, and then secure with whichever device you have available. As mentioned, you can utilize a commercial tube securement device, or you can utilize tape. One important thing to note is the endotracheal tube will be sticking out of your patient a little bit more than we're used to. Make sure that you attempt to document a depth. Some ET tubes might not have depth markings all the way to where you've inserted that ET tube. Keep in mind, we're used to measurements like 22, 23, 24 centimeters at the teeth or lips. And if we try to advance that endotracheal tube that deeply for a surgical cric, we're most likely going to go ahead and main stem our patient, and that's not a good thing. All right, so here we're going to demonstrate how to perform an emergency surgical cricothyroidotomy on our simulated patient. Thanks for playing along, Hal. First step is you want to make sure that you gather all your equipment. So I'm going to take my commercial tube securement device. I'm going to go ahead and pre-stage that by our patient, just so we have that ready. And I'm going to go ahead and select my ET tube along with my syringe. So here I have a 6.0 ET tube along with my 10cc syringe, pre-staged to make insertion a lot easier. And then I'm going to go ahead and select my scalpel. In this situation, I'm using a number 10 scalpel. After I have all my equipment ready, I'm going to go ahead and identify my landmarks. So with my dominant hand, if possible, I'm going to go ahead and stabilize the larynx and place my index finger on the patient's chin, working my way down. I'm going to feel the hyoid bone. Working my way down a little bit more, I'm going to feel the patient's thyroid cartilage. Then I'm going to feel an opening, and there's going to be a little bit of softness. That's going to be where my cricothyroid membrane is. And just below that, I'm going to feel the first cricoid ring. So in between the thyroid cartilage and the cricoid cartilage is my cricothyroid membrane. So I've identified that. Now I'm going to go ahead and take my scalpel out, stabilizing the larynx with my non-dominant hand. I'm going to go ahead and make a vertical incision. If I need to make multiple passes, I can go ahead and do that. Then, once I can visualize the cricothyroid membrane, I'm going to go ahead and take my scalpel and make a 90-degree plunge cut. Cut either towards or away from myself initially, keeping the blade inside the patient's larynx and cricothyroid membrane. I'm going to go ahead and rotate 180 degrees, cut in the opposite direction. Then I'm going to go ahead and remove the scalpel using my non-dominant index finger as a landmark holder. I'm going to make my scalpel safe, take the handle end of the scalpel, dilate the track a little bit so I know where my landmarks are and so it's a little bit easier to insert. Take my ET tube and then aim it down towards the patient's feet. And after I've advanced my ET tube, I'm going to go ahead and inflate my cuff as I normally would. Remove the syringe, and then I can secure the tube with a commercial tube securement device. I want to make sure that I note the depth at my incision for proper documentation. And then I can utilize colorimetric and or waveform capnography or capnometry in order to check for positive tube placement I can also auscultate for negative epigastric sounds and positive bilateral lung sounds.